Да. Ну, значит, не всё. The topic of our lectures, outpatient management of the patient with liver pathology. Diagnosis of the liver diseases is based on the identification of sequence development, clinical and functional syndrome, which are a combination of anamnesis, physical and laboratory instrumental science. In ambulatory praxis, it is not always possible to use all diagnostic methods. Most importantly, the timely detection of the main syndrome of liver damage may be adequate for the correct diagnosis and determine the tactics of the patient. Features of ambulatory praxis. In ambulatory praxis, it is not always possible to use a diagnostic method. Early identification basic syndromes of liver damage may be adequate to determine the correct tactics of the patient. Don't use expensive method with a small amount of information. Liver diseases is a common pathology of early disability and mortality in population. More than 1 million people get sick every year. Many identified syndrome are associated in the patient with liver pathology or other pathology because many of these are common. The main liver diseases are hepatitis, viral, bacterial, toxic, and autoimmune etiology. Progression of hepatitis leads to liver cirrhosis. Next diseases, it is liver cirrhosis. Next, it is alcoholic liver diseases. Separate nosological form because it has specific features histology. Non-alcoholic steatohepatitis. Thrombosis of hepatic vein, it is Budd-Chiari syndrome and Budd-Chiari diseases. It may be diseases of the biliary duct in the liver, hepatitis, and other pathology. It may be parasitic liver diseases. It is echinococcosis, schistosomiasis, toxoplasmosis, amoebiasis. And it may be hereditary diseases. It is hemochromatosis is hereditary diseases associated with the impaired iron metabolism. It's large absorption in intestine, an increase in blood contents and deposition in various tissues with impaired structure and function of the liver, heart, hypophysis, and other organs. And Wilson diseases is also hereditary diseases, which is based on the violation of copy metabolism. The connect of copy in the blood increase, and it is deposit in the tissues with damage to the liver, central nervous system, kidneys, and other organs. There are many syndromes that we can determine the patient with liver diseases. It is hepatomegaly syndrome, hepatorenal syndrome, pain syndrome, jaundice syndrome, syndrome of portal hypertension, edematous ascitic syndrome, cholestasis syndrome, hemorrhagic syndrome, cytolytic syndrome, immunoinflammatory syndrome, the syndrome of liver failure, the syndrome of hepatic encephalopathy, syndrome of hyposplenism, hepatorenal syndrome, and common syndrome in other pathologies. It is stenovegetative, dyspeptic, lymphadenopathy, anemic syndrome, and many other syndrome what we can determine in this patient. During the initial examination, the doctor can determine a subjective patient with a word of complaints, anamnesis. At this stage, some patients manage to find out the etiology of the diseases. Acute viral hepatitis B, C, D, or contact with such patient, blood transfusion, autoimmune reaction, nasal bleeding, chronic use of alcohol, hepatotoxic drugs, it is endometacin, tetracycline, dopagite, and many other drugs. Contact with the hepatotoxic chemicals, example of the organic solvent, and objective, determined by your doctor features of a patient's condition. The first syndrome, it is pain syndrome. Pain syndrome occurs in 60 to 70 with the liver pathology. There is no characteristic features of this pain in liver pathology. Pains are often located in epigastric region, and this patient on the outpatient basis can be treated for a long time and unsuccessfully for chronic gastritis or cholecystitis if the correct examination is not carried out. Pain in liver may be dull, long, itching, or acute paroxysmal hepatic colic. Mechanism of pain. Pain can be associated with the irritation of peritoneum covering the liver, perihepatitis in case of the tumor or abscess of the liver, stretching the capsule of the liver as it increases hepatomegaly, block of the bile duct, pain in right hypochondrium, and with hepatitis, pain can be severe and persistent. If the patient has liver cirrhosis, pain may be absent or constant, itching, dull, pressing. With the neoplasm, the grows as the tumor or cyst grows. With the heart failure, the feeling of foulness and heaviness in right hypochondrium. Acute pain in right hypochondrium can occur with the lesion of intrahepatic bile duct or blockage of the ducts with a stone, an attack of hepatic colic. Next syndrome, it is hepatomegaly syndrome. There are many diseases when we can determine this syndrome. It is liver diseases, acute or chronic hepatitis, liver cirrhosis, tumor or metastasis in the liver. It is hereditary diseases, hemochromatosis, it is Wilson's diseases. There are many infection diseases when also we can determine enlargement of the liver. It is mononucleosis, malaria, syphilis, abdominal tuberculosis, and diseases of the blood, anemia and leukemia also we can see this syndrome, and cardiovascular diseases and liver vasculitis, heart failure, Budd-Chiari syndrome. And hepatomegaly in the patient with the liver pathology is often combined with the splenomegaly. This is due to reticular histiocytic apparatus that combines these organs. Communication with the system of portal vein. Their common innervation and lymph flow. With cirrhosis and amyloidosis, the end of the liver is sharp, dense, and painless. Liver surface with the amyloidosis, smooth with the cirrhosis of the liver, and metastasis, tuberosity, with stagnation of blood. The edge of the edge is rounded, less dense, smooth, and painful. Liver density depends on the stage of liver fibrosis. Particularly dense liver consistency is observed in cirrhosis and cancer, primary or metastasis. Rapid enlargement of a liver is characteristic of acute viral hepatitis and oncopathology. Also, liver pathology is associated with the three more clinical syndromes. It is jaundice syndrome, portal hypertension, edematous ascitic syndrome. Jaundice syndrome. It is develops as a result of accumulation of large amount of bilirubin in the blood. The cause of jaundice is imbalance between the formation and excretion of bilirubin. You know the total bilirubin and direct and indirect bilirubin fraction in the blood. And there are three variants of the jaundice. It is hemolytic jaundice is caused by the hemolysis of the red blood cells and large amount of bilirubin. If the patient has this jaundice, the total bilirubin in blood rises due to indirect fraction. In urine, we can determine urobilin. Feces is intensely colored a lot of stercobilin. Obstructive jaundice is a pathological syndrome caused by the violation of the outflow of bile from the bile duct. With this jaundice, the total bilirubin in the blood also rises due to direct fraction. In urine, we can determine many bilirubin. Feces discolored, stercobilin absent, and increase alkaline phosphatase if the patient has inflammation in bile duct. And parenchymal jaundice occurs when the patient hepatocytes are affected. The function of hepatocytes and excretion of bilirubin into the bile duct decrease. Usually, parenchymal jaundice can be combined with the obstructive jaundice. Parenchymal jaundice in the blood, we can determine increase bilirubin, direct and indirect fraction. In the urine, we can determine bilirubin and urobilin. Feces slightly discolored, little stercobilin. And also, this patient has increased transaminase. Benign functional hypobilirubinemia. Disease is associated with the hereditary disorder of the bilirubin metabolism. Enzyme glucuronil transferase. They are manifested by the chronic or intermittent jaundice without changing the structure and function of the liver, and without signs of hemolytic and cholestasis. Very often it is Gilbert syndrome, but maybe other variant. It is Cragler-Nair first, second type, Durbin-Johnson and Rotor syndrome. But very often we can see Gilbert syndrome in the patient. How we can diagnostic test for Gilbert syndrome? The first, it is fasting test. Bilirubin levels usually rise after the fasting. With the increase in bilirubin of more than 50%, the test is positive. The test with nicotinic acid, intravenous administration increase the levels of bilirubin in the blood. And lymphopoietin test after introduction of the lymphopoietin of the inpatient. The level of the indirect bilirubin in the blood raises. And taking phenobarbital for 5 days leads to a decrease in the levels of bilirubin in the blood. There are 3 degrees of hypobilirubinemia, and the form of jaundice when the common bilirubin is 85 micromole per liter. Medium severity 86 to 169, and heavy when common bilirubin more than 170 micromole per liter. Next syndrome, it is edematous-cystitic syndrome. This is pathological accumulation of fluid in tissue, cavities, or organs of the human body. It is ascites, hydrothorax, and edema, and other variants. Ascites and abnormal accumulation of fluid in the abdominal cavity. In the patient with a 10-year history of liver cirrhosis, ascites occurs in more than 50%. There are many diseases when also we can see ascites. In 75%, it is liver cirrhosis. 10% it is oncological disease. It is carcinomatous, it is lymphoma, metastasis in the air of the liver gates, ovarian tumors. In 3%, it is heart failure. It is 10%, it is tuberculosis. And 1%, it is other causes. It is diseases of the pancreas, kidney diseases, internal bleeding, malnutrition, and wasting, diseases of endocrine system. Classification of ascites. There are 3 degrees of ascites. First degree, fluid in abdominal cavity, is determined only by ultrasound, computer tomography, and MRI. And second degree ascites can be defined on physical examination. And third degree tense ascites. The examination begins with the ultrasound of the abdominal organs. If necessary, a computer scan of the abdominal organs is connected. On ultrasound, computer tomography, and MRI, you can see ascites with a volume of 150 milliliter or more. And this, it is ultrasound examination of abdominal cavity and fluid. And in computer tomography of abdominal cavity, and we can see fluid in abdominal cavity. Ascites in the liver cirrhosis is associated with the several factors. Increased lymphatic formation in the liver, increase penetrability of the hepatic vessels, increase pressure in vessels of the liver, hyperaldosteronism when increase hormone aldosterone in the blood, renal dysfunction, and sodium retention in tissues. And if the patient has liver cirrhosis, this patient may have hypertrophy. And in 5 to 10% of the cases. On the right side, we can see hydrothorax in 85%, in 13% on the left side, and 2% bilaterally. Edema in cirrhosis of the liver usually occur in the late stage of diseases. This is due to factors, ascites and portal hypertension, violation, the outflow, the blood from the lower extremities, the level of albumin and oncotic blood pressure decrease. The main symptom of ascites, the increase in abdomen, the first symptom. Thinning of the skin on abdominal wall, venous collaterals on the anterior abdominal wall, umbilical hernia, dyspnea, and changing the percussion sound when changing position this patient, and positive symptom fluctuation. With the intense ascites, palpation of internal organs is very difficult. Portal hypertension syndrome. Normally, the pressure in portal vein is 8 to 10 millimeter mercury, while cirrhosis of about the 20 millimeter mercury. Pressure reaches in the portal system, maybe first degree pressure 2 to 400 millimeter of water column. Second degree pressure 4 to 600 millimeter of water column, and third degree pressure more than 600 millimeter of water column. Pathogenesis of portal hypertension. In the development of the portal hypertension defined some basic pathogenetic mechanism. Mechanical obstruction blood flow, increase blood flow in vessels of the portal system, increased resistance of the vessels of portal and hepatic veins, state collateral wells between the portal vein and systemic circulation. Classification of level the portal system block is distinguished. Portal hypertension may be subhepatic block, intrahepatic block, and suprahepatic block. Subhepatic block we can determine about the 2%. It is a portal vein thrombosis, congenital anomaly of the portal vein, compression of portal vein by tumor, and inflammatory formation of the pancreatobiliary region, pancreatitis. It may be splenic vein thrombosis. Intrahepatic block, it is very often variant, and we can determine in 80 to 90%. Usually it is liver cirrhosis, tumor, parasitic liver damage, and maybe hemangiomas of the liver. And suprahepatic block about the 10%. Violation of the outflow, the venous blood flow from the liver with the damage to the hepatic vein or the inferior vena cava. This blood cherry syndrome. And maybe mixed block. It is liver cirrhosis complicated with the portal vein thrombosis. The main symptom of the portal hypertension. It is dyspeptic syndrome, especially after eating, bloating and feeling of the fullness after eating, flatulence and grumbling, progressive weight loss, periodically diarrhea without pain and fever, and then feel better. Splenomegaly, ascites, oliguria, a very formidable complication, gastric and rectal bleeding, portal-caval encephalopathy. Diagnosis of the portal hypertension, we can determine on the endoscopy, esophagus and stomach, and X-ray examination of the esophagus. Esophagus varicose vein maybe have 3 degree, first degree. The diameter of a veins is not more than 5 millimeter, and they are locates only lower third of the esophagus. Second degree, the diameter of the vein is from 5 to 10 millimeter. They are located in middle third of the esophagus. And the third degree, when size of the vein is more than 10 millimeter, and we can see varicose vein in all part of the esophagus. It is 3 variants. It is first degree, second degree, and third degree. And in the endoscopy, we can see different degree of the varicose vein. And varicose vein on the of the esophagus on X-ray examination. Portal vein, we can portal hypertension we can determine during study diameter of the portal vein. The normal diameter during exhalation less than 10 millimeter. On the inhalation 12 millimeter. And you must remember that during if the portal vein don't change diameter during the breathing, it is also signs of the portal hypertension. After bleeding, the pressure in portal vein can be reduced. And hepatic encephalopathy, a complex of the disorder central nervous system that develops as a result of acute or chronic hepatocellular failure and portal-caval shunting. The main role of the development of hepatic encephalopathy play ammonia, fatty acid, phenols, and mercaptan. Factors contributing to increased hepatic encephalopathy. A lot of food protein, intestine dysfunction, it is the constipation and diarrhea, a gastrointestinal and other bleeding, rapid dehydration with diuretics, arterial hypertension, anemia, taking psychotropic drugs, especially phenazepam, siduxane, progression of liver damage, and portal systemic shunting. There are several stages of hepatic encephalopathy. The first stage, the initial, is characterized by the initial signs of mental and neurological disorder. There is a sleep disorder, apathy. Second stage, it is the decompensation, are aggravated the symptom of the first stage. It appears constant sleepiness, flapping tremor, positive syncope, irritability. It is symptom flapping tremor. Third degree terminal. The patient in the sofa and badly reacts to stimuli. And fourth degree, it is coma. Absent of movement, no reaction in all stimuli. How we can determine present or absent hepatic encephalopathy? There are psychometric testing and we can use for a diagnosis hepatic encephalopathy. The sensitivity, the test is high, 70 to 80%. Many simple psychometric tests have been developed. It is a number connection test. It is a digit symbol test, serial dotting, and the line transing test. And then we can determine in outpatient present or absent encephalopathy. It is number connection test if you want to determine present or absent encephalopathy in this patient. Outpatient, we must do laboratory examination this patient, general blood analysis, general urine analysis, blood chemistry. It is bilirubin and fraction, total protein and fraction, albumin, enzyme, IST-ALT, and alkaline phosphatase. Lipid metabolism indicators total lipids, cholesterol, coagulogram indicators, urea and creatinine. And we must do markers of viral hepatitis A, B, C, D, E, and others. And markers of autoimmune hepatitis, anti-nuclear and anti-mitochondrial antibodies. And there are other, but it is very important. With an acute process, ILT and IST increase by more than 5 to 10 times and increase antibody M, alpha-1 and alpha-2 globulins. And Veltman's test 3 or 4 tubes. With the chronic process, IST and ILT increase by no more than 2 or 3 times and increase antibody G and the gamma globulins. And the Veltman test 9 to 10 tube. If you can calculate the Deritis index. If this index less 1, usually it is viral hepatitis. If 1 to 2, it is maybe different chronic hepatitis, dystrophic liver damage. More than 2, 4, it is for alcoholic liver damage. And if the patient alcoholic liver diseases, the increase in size of erythrocytes more than 100 femtoliter. And we can do a FibraMax. This test is based on complex analysis. It is 10 biochemical indicators: alpha macroglobulin, gaptoglobin, apolipoprotein, gamma glutamine transpeptidase, total bilirubin, transaminase, blood glucose, triglycerides, and total cholesterol. If we can determine active test for the diagnosis degree of inflammatory, ASH test for diagnosis alcoholic steatohepatitis, NASH test for diagnostic of non-alcoholic steatohepatitis, and fibro test diagnosis the presence and degree of fibrosis of this patient. The degree of inflammatory activity clinical and laboratory examination may be absent, minimal, moderate, expressed. How we can determine the degree of activity chronic process? It is a complex clinical data. It is a jaundice, subfebrile condition of this patient. And then we can think about the different degree. And we can use serum transaminase ILT and IST and active test FibraMax. If usually we determine the transaminase and then think about the degree of inflammation. Minimum when increase transaminase levels 2 or 3 times. Moderate increased transaminase levels 5 to 10 times, and expressed transaminase more than 10 times higher than normal. And we must do instrumental method examination of the liver. Liver ultrasound. Ultrasound of the liver to study the hepatic structure with visual assessment and complete quantitative characterization of portal and intrahepatic blood flow. Liver elastometry. Elastometry is a method for determining the stage of fibrosis using the fibra scan apparatus, which allows to establish the degree of liver fibrosis within 5 minutes. And we can use computer tomography and MRI of the liver. This method provides an image of the organs in the form successive horizontal sections through the use of X-rays. And we can do endoscopic examination. And we can determine varicose vein in esophagus, stomach, and determine condition of the mucous membrane of stomach and duodenum. When outpatient treatment is possible and established diagnosis, the minimum degree of inflammation activity, mild jaundice and ascites, the initial stage of hepatic encephalopathy. And most often these are patients with the Gilbert syndrome, chronic hepatitis, compensated liver cirrhosis, with initial signs of subcompensation of pathological process. Basic therapy is complemented by the drugs for the prevention and treatment of frequent complications. Treatment is carried out in 3 main directions. Preventions of bleeding from the varicose vein, prevention and treatment of encephalopathy, and elimination of ascites. Basic therapy in diffuse liver diseases include the first, it is diet, number 5, with restriction of the salt, medication, normalizing gastrointestinal function, it is antibiotics, it is enterosorbents, it is probiotics and prebiotics. And if necessary enzyme preparation, creon, pancreatine, festal, and others. And next we must use group, it is hepatoprotectants. There are many variant hepatoprotectants. It is preparation of the medicinal plants. It is preparation of based on the adamethionine. It is preparation of the bile acid, essential phospholipids, animal origin medications, and alpha-lipoic acid preparation. And also we can use vitamins C, B, E groups and others. And we must do syndromic therapy and treatment in the patient with the concomitant diseases. If the patient has Gilbert syndrome, we must use basic therapy, diuretics, drugs, alcohol, halenzin, short courses of the phenobarbital, which increase glucuronil transferase activity and decrease indirect bilirubin, and normalization of intestine peristalsis. It is Therucal domperidone. If the patient has chronic hepatitis, also we must use basic therapy treatment is carried out until the normalization of transaminase, ILT, IST, and decrease the levels of bilirubin. The patient are shown bed rest in horizontal position. Hepatic blood flow improves, metabolic process improves, level cells are restored. The patient's motor activity is gradually expanded. Treatment of pain syndrome. We can use spasmolytics, atropine sulfate, papaverine, platifilin, drotaverine, and non-steroidal anti-inflammatory drugs, and other analgesics, analgin, droperidone. Medication of the portal hypertension and prevention of the bleeding. All drugs can be divided into the two main groups. The first group, it is vasodilators, affect the resistance vena portal. It is nitrates. And second group, it is second group, that is beta blocks. And we can use vasoconstrictors. They constrict blood vessels and reduce the amount of the portal blood. It is vasopressin and somatostatin to inhibit the activity of endogenous vasodilators, especially glucagon. Principally of the outpatient treatment for ascites. For the cirrhosis, apply low salt diet, no more than 2 grams of salt per day, and in some cases completely salt-free diet. Limit fluid intake and diuretics and potassium preparation. The dose of the diuretics drugs is selected individually. Control is needed. Drinking liquid diuresis, body mass, daily weighting, serum indicated, creatinine, sodium, potassium once a month, and mental status and ECG in this patient. With adequate therapy for ascites, the patient should lose about the 500 grams every day. For the treatment of ascites in liver cirrhosis, it is better to use a combination. It is spironolactone and furosemide and potassium preparation, aspartame, panangin. Taking these drugs in isolation is less effective. If we cannot positive effective, we must increase dose these drugs. With a good result, the treatment furosemide is first gradually cancellate then spironolactone. If necessary, diuretics are prescribed on an individual basis. You must remember that long-term use of the diuretics contributes to the development of the portocaval encephalopathy, renal failure, electrolyte disbalance, hyponatremia, and hyperkalemia. In men, the use of high doses of spironolactone leads to develop of the gynecomastia and erectile dysfunction. In case of ineffectiveness of conservative therapy, the patient must be hospitalized for the inpatient treatment, for the therapeutic paracentesis or surgical treatment, liver transplantation. Treatment of the hepatic encephalopathy. It is protein restrict diet to 20 to 50 gram per day. Gives priority to vegetable protein. And detoxification therapy. It is cleansing animals, removes toxic substance from the body. And all drugs reduce ammonia. Drugs that help reduce formation and absorption of ammonia in the intestine. It is polysalt lactulase and antibiotics. And preparation increase neutralization of ammonia in the liver. It is glutamic acid, gepamert, hepasol. And drugs with different mechanism of action. Nootropic agents, it is flumazenil, improves blood circulation in the brain. It is drugs of amino acid which normalize of amino acid the composition of blood. It is falcamin and preparation of the zinc we can use in this patient. Essential drugs for treatment of hepatic encephalopathy. It is three drugs. It is lactulose, rifaximin, and ornithine aspartate. Lactulose does not affect the composition or function of the intestine microbiota, accelerated intestinal peristalsis. As a result, the production of the ammonia in intestine decrease and its excretion in feces increase. Rifaximin is not non-absorbable antibiotics that has a possible effects on the microbial composition of the intestine, which leads to decrease in ammonia production. And ornithine aspartate, the drugs stimulated the enzymes involved in the detoxification of ammonia. Prevention of the non-alcohol steatohepatitis, regular prevention examination, timely treatment of the diseases that can lead to the development of pathology, diabetes mellitus, and other endocrine disorder, obesity, weight loss, correction of dyslipidemic disorder, reducing the use of drugs that contribute to the development of steatohepatitis, antibiotic, cytostatics, hormones. If the patient has alcohol hepatitis, the basis of prevention is rejection of alcohol. For mild and moderate severity of alcohol hepatitis, the prognosis is good. Treatment is conducted by the therapist and narcologist. With the continued alcohol intake, disease is complicated by liver cirrhosis, which is the final stage of alcoholic damage. Dispensary observation of patient with the chronic hepatitis. Chronic hepatitis without treatment leads to the liver cirrhosis. At the minimum degree, the hepatitis activity shows examination by the therapist once a year. With the moderate and severe process activity, 3 or 4 times a year. We must do biochemical analysis of the blood 1 or 2 times a year with the determination bilirubin, transaminase, alkaline phosphatase, cholesterol, total protein, and its fraction for the evaluation activity of the process and selection of the therapy. This study of the blood, the patient 1 or 2 times a year for markers of hepatitis B, C, and others, and liver ultrasound once a year. Instruction the patient with liver cirrhosis leads a normal life, normalized food, rejection of alcohol, reduce the physical stress, control weight, diuresis, fluid drunk, abdominal cycle, control the frequency, defecation, as constipation give direct connection with the hepatic encephalopathy. That's all.